Good afternoon, dear colleagues. We today will continue our second part of our webinar concerning on drug-related problems and drug safety in elderly. Today we will talk about pharmacodynamic and pharmacokinetic in elderly patients, why it's important, and which difference between, for example, if you will compare with younger persons, with adolescents, because of it will depend on the efficacy of drug and safety of drugs, and you should remember it. And we will talk today, right now, factors, start talk concerning on and about factors increased risk of adverse drug reaction in the elderly patient. For our new participants, and I'm happy for your questions which I have received yesterday. It was very interesting because this topic what I see has interesting because now population getting older, and if you compare elderly patients in population, it's now enough big part of our population. And if you compare, for example, Japan, Chinese countries, and you can see that people are living longer, and these people deserve, elder people deserve higher quality of life, and this group of patients has more diseases, diagnoses. It's why bigger risk of polypharmacy as well, and comorbidity has a place to why. I will make accent on it today because I am a medical doctor in my past life, but it's in my blood, and my approach is looking on patient as a complex, because patient has many diseases, many diagnoses. This patient taking not one group drugs because of this patient has many diseases. For example, arterial hypertension, diabetes mellitus, problems with heart, ischemic problems with heart, and in some cases even stroke of heart. It's problems with joint. It's why it's important, because general process, it's endothelial dysfunctions, it's problems in wall of vessel and tendency of vasoconstriction of vessel. It can be problem parallel with kidneys, because arterial hypertension can be and has central genesis, and it can be involved to kidney as well too. As assumed factors increased risk of adverse reaction in elderly patient, we can notice that this group is suffering from chronic illness, so long-term use of medicines multiplies health problems, polypharmacy multiply drug usage. It's why polypharmacy has problem and medications errors and from patient's part. And if, for example, medical doctor is not taking account problems concerning on interaction, drug interaction, and can be drug disease interaction, and we will talk about it, making accent precisely on elderly patients group. It's an appropriate administration of the medication It's age-related change in pharmacokinetics, pharmacodynamics. From this reason, we can see different, can be different pharmacokinetics, pharmacodynamics, and it can influence on effectiveness, efficacy of drug, and increasing burden of comorbidity. And when I will talk about it, I want pay your attention that this problem, how we can solve this problem. It's when medical doctors has appointment patients and before administrate drugs, it can be easy to collect pharmaceutical anamnesis. What kind? It's like anamnesis of life, but taking making accents on groups of drugs which taken this patient or allergic reaction. And don't forget about allergen between, for example, antibiotic. If, for example, patient has allergen taking antibiotics like amoxiclav, and in these groups, this patient can have allergic on, for example, macrolides like erythromycin and clarithromycin, and another group, another drugs of macrolides. It's important too, and this is connected, and for example, with allergic on iodine. Iodine. It's important why? Because it can be allergic on diagnostic iodine taking contrast media, for example, Yohexol as well. Plus, don't forget about amiodarone, which in its structure has iodine as well, and it can be a reason of allergics of this drug too. Now we will talk about pharmacokinetic, pharmacodynamic determinants of drug action in the elderly, and we will pay attention on delivery, absorption, destitutions, removal, its taken, metabolism, and elimination, and it's involved as pharmacokinetics characteristic and pharmacodynamics. And what pay attention in this process, it changes in receptors responsiveness. It's maybe we can pay attention on different sensitivity of receptors, affinity of receptors. And why? Because different affinity of receptors will dictate different efficacy as well too. And it's physiological hormone static regulation too. And you remember that parallel problems this group of patient elderly has with homeostasis too. Which identify risk factor associated with adverse reaction in elderly. And with assume this information, I can pay attention in group. It can be patient-related risk factors, it can be disease-related risk factors, it's medication-related factors, and other factors. Patient-related factors include age, female sex, and several sources reflects that exactly a female has more adverse reaction compared with male. A rural residential location and socioeconomic status too. Disease-related risk factors, it's what we pay attention before, it's comorbid burden. It's cardiovascular disease because of age, because of process of aging, and problems with inflammation in vessels, wall of vessel, endothelium and endothelium dysfunction as well, which this process I will time pay attention to this lecture because it's connected with tissue hypoxia as well, and we see that complex diseases, problems with heart, cardiovascular disease, diabetes mellitus, arterial hypertension has same pathophysiology, and but don't forget that it's different groups of drugs which has target on pathogenesis of this disease, and we see even looking on these pictures that one patient will have several groups of drugs which these groups of drugs can interact. Plus, for example, I will pay attention, but if a patient has problems with joints, it means that non-steroidal non-steroidal drugs like ibuprofen can make worse problems. For example, with hypertension, it's examples. For example, it's examples interaction drug disease interaction. Plus, many this we will in future lectures will discuss and I will show on cases how it's look like, and in cases how it's work, this complex approach. It's not difficult. Why all time pay attention? Because medical doctors, healthcare professionals, and physicians and another specialist medical doctors, for example, gastroenterologists, looking on this problem and trying to help patient with treatment, administrate drugs, for example, ulcerative disease and ulcerative disease of, for example, stomach, and this group can interact and same patient can have problems with joint. What to do with it? Many interesting cases we will discuss. Disease-related risk factors include cancer, depression, impaired renal function. This impaired renal function and with disorder of elimination can influence on dose of drugs, because this group of patients each with problems aging older patients and parallel with impaired renal function, it's problem with dose. The group of patients will need less dose compared with patients without impaired renal function. It's dementia, it's hyperlipidemia, it's elevated white blood cell count, which will show majority cases and present on inflammation in this patient, because for example neutrophilia and show, for example, this patient has some inflammation, for example, from some organs. It can be and from otitis to some bigger problems, and you should investigate a patient, because we talked about in previous lectures that all the patient has tendency to have inflammation as well too. And don't forget about liver diseases, which influence on for example, you remember the Tachrom 450 system, which influence on disintoxication of drugs, and in this group of patients, toxicity of drugs can be higher compared with group patients without liver disease. Medication-related factors include a number of medication, polypharmacy, and it's not should be more than 5 drugs, and you still have to take into account what kind of groups of drugs, what are adverse reaction, plus these groups of other groups of drugs has drug interaction, other group reaction, other groups of drugs has drug interaction with drug in other group, or drug with disease. Don't forget about present drug interaction with medical devices, with food, and it still has significant of adverse reaction exactly, precisely in elderly group. It's what kind of medication? Antihypertensive medication, antithrombotic, anticoagulant medication, antibacterial indication, non-steroidal anti-inflammatory drugs, anti-diabetic medication, psycholeptics as well too. And don't forget about other factors. It's drug-drug interaction, drug-disease interaction, drug-device interaction, drugs-food interaction. It's history of falls and limitation in activity of daily living. This picture age-related change in pharmacokinetic is some problems in elderly patient. When we're talking about absorption, GI motility going down, it's decreasing, splanchnic blood flow decreasing, mucosal surface area decreasing, and first pass metabolism decreasing. When we're talking about second stage of pharmacokinetics, is distribution, taking into account body fat increasing, lean body mass decreasing, body water decreasing in elder patients, serum albumin decreasing, and serum glycoproteins increasing. Metabolism stage, including change 2 in elderly patients, it's decreasing hepatic blood flow, it's decreasing liver mass, it's phase 1 metabolism decreasing, and phase 2 metabolism can be changing. And elimination, you see that metabolism connected with function of liver and GI tract, it's important too, and gastrointestinal tracts, and it's can be problems with in different parts on gastrointestinal tract. Elimination, including we make focus on kidney function, its nephron size, its renal blood flow, nephron size in elderly patient decreasing, and renal blood flow decreasing too, enterohepatic blood flow decreasing too. We will continue and make precisely focus age-related change in pharmacokinetics. Why it's important? Because I will show you examples. And for example, absorption changes may be slowed, but the adsorbed share is most often not affected, but changes due to decreased function of ventricle intestines and the blood flow to the intestines. Clinical importance low, but little, but still you still remember these changes. Distribution. Decreased volume and distribution of hydrophilic drugs and increase in volume of distribution of lipophilic drugs. Decline in fat-free mass and increase in body fat with aging. Important for some drugs, and as examples you can see, it can be vancomycin, amiodarone, diazepam, flunitrazepam may have increase in plasma half-life, and water-soluble drugs as digoxin and lithium have higher peak plasma concentration and shorter half-lives. Metabolism. Hepatic metabolism may be reduced, and decreased hepatic blood flow and liver mass change due to this hepatic metabolism reducing, and we see as a result decreased hepatic blood flow and liver mass. And it's important for several drugs. It's important for amlodipine, diltiazem, ropinirole, and theophylline. Renal elimination. Renal elimination is reduced in elderly patients, and it changes due to decreased glomerular filtration rate. It's very important, clinical importance. And drugs, as example, is digoxin, gabapentin, glipizide, and hydrochlorothiazide. When we're talking about it shows still, but without, as example, you see that we talked about, but now it's more divided and potential impact, for example, for immunosuppression. It's mean too, because we see that it will increase problems with immune system too. Bioavailability, the extent or rate at which the active substance enters the systemic circulation to reach the action site can be modified. And we talked about it too, that after absorption is distributed to different tissues and organs with increase of fat mass and reduction in volume of water. The volume of distribution of fat-soluble medication increases, as does the half-life of the same. And why you repeat it, because it's important. The half-life increases, and it means that the drugs persist in organism longer, and maybe you should talk first of all half-life longer. It means that little bit later patients should take these drugs, because acting of these drugs in this organism of this patient is taking longer because of increases in longer half-life. And in the case of long acting, for example, benzodiazepines. Benzodiazepines, it's psychotropic drugs, and benzodiazepine has, we talked about some adverse reaction, and we will talk about influence on cardiovascular disease and exactly Q-tap prolongation interval. It will be another lecture, and it's ready, and I will show you as soon as possible, because it's important too. The water-soluble drugs may have a lower volume of distribution, lower, it means less, smaller of distribution, with an increase in plasma concentrations that can be toxic, as happens with such drugs as gentamicin, digoxin, theophylline, and cimetidine. It's a different group of drugs, but still it has same problems of lower volume of distribution, because these drugs is water-soluble drugs, and its increase in plasma concentration in these groups can be higher toxic in elderly patients because of it. You should remember it. In addition to body composition, the two main proteins involved in the transport of drugs, it can be albumin, which binds to acidic drugs as warfarin, digoxin, lorazepam, and alpha-1 acetylglycoprotein, which binds mainly to basic drugs as lidocaine, propranolol, may have their plasma concentration altered in all the populations with comorbidity. Exams from absorption drugs in elder patients, the amount of levodopa absorbed increased in elderly because the dopa decarboxylase levels in gastric mucosa diminish with age, and therefore less levodopa is degraded in the stomach. For example, antacids decrease the oral absorption of H2 antagonist as cimetidine, ranitidine, and alcohol accelerates the absorption of chloral hydrate. Drugs distribution in the elderly patient in second stage in pharmacokinetics, and when we're talking precisely about it more in details, the distribution of a drug is influenced by tissue blood flow, plasma protein binding, and the physiochemical properties of the drug itself. It is influenced by lean and non-lean body mass, total body water, and extracellular volume. Adipose mass increases with aging while total body water is reduced. The distribution volume is slower for water-soluble drugs and greater for lipid-soluble ones, such as verapamil, diazepam, nitrazepam, amitriptyline, and amiodarone. Therefore, these drugs tend to accumulate in the adipose tissue, and consequently their plasma half-life and their action increase, so cause the risk of adverse effects in the elderly getting higher. The body distribution of medication can be affected by changes in body composition and changes in protein binding as well too. The body distribution of medication can be affected by changes in body, and you will see it in exams too, that the elderly usually have increase in adipose tissues, decrease in lean body mass, and reduction in total body water, while concentration of water-soluble drugs getting higher because of reduction of total body water, and as a result is getting higher toxicity of drugs exactly soluble, water soluble. This alteration can cause significant changes in the volume distribution of various medication. For water-soluble drugs, the reducing volume distribution can increase the initial concentration in the central compartment, causing higher plasma concentration, as in the case of cimetidine, digoxin, gentamicin, and theophylline. The elderly also tend to have decreasing albumin and increasing alpha-1 acetylglycoprotein levels, which can make the elderly more susceptible to acute effects of multiple drug therapy when highly protein-bound drugs are prescribed together. Cardiac output is often reduced, and peripheral vascular resistance increases, leading to a decrease in total systemic perfusion of the vital organs, including the kidneys and liver. This reduction of perfusion can decrease the body's ability to metabolize and excrete drugs. When we're talking about, and I pay your attention age-related change in pharmacokinetic and exactly metabolism. Also, other organ can metabolize drugs. The liver is the main organ involved in the process. Metabolism consists of converted and active substance in simpler and more polar substances called metabolites from phase 1 and 2 reaction. These metabolites are inactive or have modified activity. In the liver, maintaining its function during aging, there are changes that can reduce its functionality. The hepatic volume decreases on 20–30%, and the hepatic blood flow 20–50% decreases easily too. There is its reduction in the first pass hepatic effect, and so the bioavailability of drugs that are subjected to extensive first pass metabolism may be increased, while others which need activation in the liver may be reduced. In addition, the hepatic clearance of drugs subjected to limited flow metabolism, as examples you can see propranolol and amitriptyline, can be reduced by more than 40%. Age can significantly affect the pharmacokinetics of drugs with narrow therapeutic index, reduced margin between an effective dose and toxic dose. Inflammatory condition can also affect the function of the enzymes involved in metabolism. The microbial ecosystem also stands out, with many clinically relevant drugs being co-metabolized by microflora. With changes in the composition of the intestinal microbiome, the drug's metabolism can also be altered with harmful consequences. Changes in drug metabolism can elevate drug responses in elderly patients too. There is a decrease in hepatic blood flow compared to 25 years old, resulting in a major reduction in the first pass metabolism of the drugs. Medication subject to oxidative phase 1 metabolism exhibit decreased elimination because phase 1 metabolism is catalyzed by the cytochrome P450 system in the smooth endoplasmic reticulum of the hepatocytes, a process that diminishes with age. Some antihypertensive medicines that are affected by the first pass metabolism include propranolol, verapamil, and nifedipine. Phase 2 metabolism, which involves the conjugation of a drug molecule by glucuronidation, acetylation, or sulfation, is not generally affected by age. For example, if an antihypertensive drug listed above is prescribed to an elderly patient and taken together with a potent cytochrome 3A4 inhibitor, a potential serious drug interaction can occur, leading to toxicity. And you see how it's worked, that drug, first of all, is oxygenated metabolite. It's going to conjugated metabolite, and then it's going to excretion. Excretion is also affected by the aging process. The kidney is the main organ in the removal of drugs, and their metabolites and their pharmacokinetics are strongly influenced by the progressive loss of kidney's function with age, thereby decreasing the excretion of drugs. Due to these changes, a decline in total clearance with the age is expected for drugs predominantly excreted by the pathway. With the decrease in clearance, serum levels will increase, potentially causing adverse reaction. Therefore, the dosage of these drugs must be guided by kidney function and the glomerular filtration rate, GFR. Polypharmacy can increase the risk of kidney dysfunction, overloading the kidneys to excrete several drugs, and their metabolite is the same part. And you see how cytochromes play a role. And you see, for example, that there are substrates drugs, there are inhibitors drugs. When we're talking about cytochrome systems 450, and you see types of cytochrome, it can be cytochrome 2b6, cytochrome 2a6, cytochrome 2c19, cytochrome 2c8, 918, cytochrome 3a457, cytochrome 1a2, cytochrome 2a2, cytochrome 2d6, cytochrome a6. And you see that majority problems has when we're talking about changes in activity cytochrome P3A457, and it can be, when we're talking about substrates, it's drugs midazolam, nifedipine, erythromycin, erythromycin, and cyclosporin. When we're talking inhibitor of cytochrome 3A457, it's ketoconazole, histidine. And inducers of cytochrome 3A457, it's fenofarb, rifampicin, dexamethasone, and carbamazepine. We see problems, for example, coumarin, methoxsalen. Coumarin is substrate inhibitor, methoxsalen, phenobarb. Mephenatine, omeprazole, its problems with cytochrome 2C19, it's around 5% disorder. Substrate is mephenatine, omeprazole, inhibitor fluconazole, phenobarbital, rifampicin is inducing. Cytochrome C2C8, substrate is tolbutamide, warfarin, phenytoin, sulfaphenazole, its inhibitors, and inducers is phenobarbital, rifampicin 2, similar as cytochrome 2C19 in category inducers. We keep going. And cytochrome 1A2 substrate is caffeine, theophylline, tecrine. It's a substrate of cytochromes. Inhibitors, it's furaphyline, fluvoxamine, and inducers, it's omeprazole, tobacco, smoke. And you see that we now talking about tobacco smoke is the factors of inducer cytochrome 5, cytochrome Y1A2. And you see another group, why it's important. I will pay you attention, for example, inducers on cytochrome 2A1, it's ethanol and isoniazid. Inducers is cytochrome type, and inhibitors tetrahydrofuran DDBTC, and the substrate is chlorzoxazone. What's going on with hepatic clearance with age? Hepatic clearance decreases with age, and its influence the decrease hepatic blood flow, plasma protein binding, decrease in hypoalbuminemia, displacement by other drugs, decrease in activity of liver enzymes and transporters, liver failure, specific inhibitors of induction by drug, genetic polymorphism, other factors, nutritional state, comorbidities, other drugs, hepatic disease, cirrhosis, alcohol liver disease, carcinoma are more common in elderly liver ability to recover from injury. Drugs with a higher intrinsic clearance are rapidly metabolized at a rate of drug loss indeterminate by hepatic blood flow. It can be diltiazem, lidocaine, imipramine, metoprolol, nifedipine, propranolol, and verapamil. Congestive HV, it can be shock hepatic disease, reduce the dose can be up to 40%. Drugs with low intrinsic clearance are slowly metabolizing. A rate of elimination is mainly dependent on enzyme activity in the liver. It can be carbamazepine, diazepam, phenytoin, theophylline, and warfarin. And you see groups, drugs, and I showed you that age-related decrease in hepatic clearance found, and what not age-related differ found. And when we're talking about age-related decrease in hepatic clearance found, it can be alprazolam, barbiturates, carbenoxolone, chlordiazepoxide, chlormetazole, clobazam, desmethyldiazepam, diazepam, fluorazepam, imipramine, meperidine, nortriptyline, phenylbutazone, propranolol, quinidine, quinin, theophylline, and tolbutamide. And no age-related difference found in hepatic clearance. It's ethanol, isoniazid, lidocaine, lorazepam, nitrazepam, oxazepam, prozazine, sortilate, and warfarin. The determination of drug metabolism can have influence with drugs, tobacco, alcohol, occupation, exposure, pollution, diet, and you should not forget about individual phenotype. It includes genetic factors and host factors. Genetic factors include development programs, multigen factors, polymorphism, inborn errors, and host factors, therapeutic invention, working load, liver disease, other diseases, and hormonal milieu. Cytochrome 384, most abundant in liver, around 30%, and good. Metabolized is more than 50% of all drugs. Substrate is midazolam, simvastatin, nifedipine, cyclosporin, quinidine. Numerous interaction, antimycotic, inducible by anti-epileptic, rifampicin, steroids, decline considerably during aging. Most abundant in liver, and we talked about this important relative mineral in liver. When talking cytochrome 296, 2D6, its relative mineral in liver less than 4%, metabolizes more 50 drugs. Substrate is midazolam, simvastatin. Genetic polymorphism, more than 50 variant alleles known. Poor metabolizer phenotypes, numerous interaction, quinidine, very little declines during aging. Example of drug metabolizing by cytochrome 2D6 is captopril, debrisaquine, dizapramine, dextromethorphan, fluoxetinin, haloperidol, lidocaine, metoprolol, paroxetine, fenformin, propranolol, spartiene, tiorizidine, and timolol. Drug treatment in elderly. More important using group of drugs is beta blockers, metoprolol, metabolically cleared cytochrome 296 others, large interindividual variation, age not important factor. We now start talking about what kind of treatment are using more often in elderly patients. Cetalol, renally cleared, small individual variation, and decrease in renal function. Multiple reasons why all the adults are especially impacted by polypharmacy. Polypharmacy is big problem in elderly groups of patients, and it can be reason of negative interaction, and in some cases can be reason even of lethal case and encephalopathy, because you should remember that polypharmacy, as a result, it can be negative again interaction, drug interaction, drug disease interaction, drug food disease, and you should understand taking pharmaceutical anamnesis parallel with anamnesis of life, anamnesis of disease, that exclude these factors which can be has negative influence of patient and be reasons of serious adverse reactions. Older individuals are at great risk of adverse reaction due to metabolic changes and decrease in drug clearance associated with aging. This risk is compounded by increasing numbers of drug used. Polypharmacy increases the potential for drug-drug interaction and prescription of potentially inappropriate medication. Polypharmacy is an independent risk factor for hip fractures in older adults. In other case control study, also the number of drugs may have been an indicator of higher likelihood of exposure to specific types of drug associated with false central nervous system active drugs. It's cyclic tetracycline, it's paroxetine, can be, we will talk about these groups, why. From one side, you remember the older patient has problems with density of bones, another it's osteoporosis, and its risk is, I can tell, is factor of risk, it's fall down, falling, which can be reason these fractures. Polypharmacy increases the possibility of prescribing cascades. A prescribing cascade develops when adverse reaction is misinterpreted as new medical condition and additional drug therapy is then prescribed to treat the medical condition. Below, prescribing cascades are part of the definition of problematic polypharmacy. Use of multiple medication can lead to problems with adherence in older adults, especially if compounded by visual or cognitive impairment. 2017 systematic review observation studies suggested the drug regime and complexity is associated with medication and adherence as well too. Age-related changes in pharmacodynamics. In all the adults, when we're talking now about what different, why it's important pharmacodynamic in aging patient and old adults. In all the adults, sensitivity meaning the effects of the same concentration of a particular drugs at the site of action vary significantly when comparing with young of adult persons. This difference can be justified by changes in drug receptor interaction, signal transduction, adaptive homeostatic responses, and among more fragile patients by comorbidities. Also, age-related pharmacokinetic changes are predictable. The complex interaction between pharmacokinetic changes and homeostatic changes make it a difficult topic to study right now. The most relevant pharmacodynamic changes are the central nervous system and cardiovascular level. Older adults often demonstrate an exaggerated response to psychoactive drugs due to underlying age-related decline in central nervous function and are also more prone to adverse effects with cognitive impairment, including confusion and drowsiness. At the cardiovascular level, they may experience a greater decline in blood pressure after administration of calcium channel blockers with or without dihydropyridine, which may be the result of related changes with age in the reflex of baroreceptors, as well as a decrease in clearance of these drugs. In addition, beta-adrenergic receptors decrease in number and have less sensitivity and also show changes in the G protein involved in signal transduction. As a result, beta adrenergic activity in vascular, cardiac and respiratory tissue decreases, alters the effect of beta-blocking agents and beta-agonists in general. Pharmacodynamics not only affects the therapeutic effects of the drug, but can also change the magnitude of the effect with the subsequent adverse effect. These changes in pharmacokinetics and pharmacodynamics can thus make the older population more prone and susceptible to adverse reaction either in normal therapeutic doses or by drug interaction mechanisms. As previously mentioned, physiological aging cause pharmacodynamic and pharmacokinetic changes, imposing different pharmacological responses. The drug could trigger iatrogenic problems in geriatric patients, increasing the risk of possible adverse reaction. Why elderly more sensitive to drug? Because, first of all, as assumed, reducing amount of water in the body, fat-soluble drugs remain longer in the body with prolonging effects of importance for some sedative and anxiolytics. Reduced kidney function, decreased excretion of some cardiovascular drugs, some antibiotics, diabetic drugs, anti-inflammatory drugs need to reduce dosage. Reduced liver function, decreased metabolism of opioids, benzodiazepines, and some antidepressive drugs. Brain and nervous system more sensitive to psychotropic analgesic drugs, dizziness, and confusion. Decreases capacity to regulate blood pressure fall, fainting, vertigo when using drugs for hypertension. Gastrointestinal sensitivity to anti-inflammatory drugs can be reason of bleeding. Drug treatment in the older age defining problems, and we can see that it can be extrinsic problems, prescribing patterns, excessive amounts, inadequate indication, excessive duration, inappropriate regimens, and drug compliance. And when we're talking about drug treatment in the older age, defined as the problem, another group is the intrinsic problems: pharmacokinetics, absorption, distribution, metabolism, excretion, and pharmacodynamics. And when you assume it, you should you should remember that this group very sensitive for adverse reaction, elderly patient, because reduced responsiveness, we're talking about adrenergic drugs. Unchanging responsible can be most drugs, but you should remember about increasing responsible concerning on benzodiazepines and warfarin. Risk for the drug toxicity in the elderly. One of it is elderly, a decrease in lean mass, increase in fat storage, decrease in renal function, and decrease in hepatic function. Psychological risks: demanding personality, caregivers, poverty, complex medication regimes. And adverse reaction, overall incidence of these problems, linearly related to the number of medication, which in turn reflects the number of acute and chronic illness, associated with increasing risk for hospital admissions, cognitive impairment, injuries, falls, and other adverse outcomes, errors in prescribing drugs, age-related pharmacokinetic changes not taken into account, unawareness of incompatible combination, errors in drug use by patients, non-compliance use of non-prescription drugs. Common drugs reaction can be confusion, ataxia, falls, postural hypotension, urinary retention, constipation. Careful drugs, over-the-counter drugs. Drugs interaction in elderly patients with diseases. It can be drug interaction between congestive heart failure, decreasing clearance of many medication, being prostatic hypertrophy, obstructive symptom with anticholinergic drugs, Chronic renal insufficiency, when we talk about non-steroid and non-inflammatory drugs, aminoglycoside, contrast dye. Postural hypertension may be worsened with diuretics, antihypertensives, tricyclic antidepressants, levodopa, vasodilators, and others. And dementia, when we're talking about superimposed delirium, can result with an anticholinergic. You remember that there is anticholinergic even syndrome, opiates, and psychotropic agents. Some common disease and illness in elderly patients with medicine, with drugs. Diabetes, this state. Aggravated drugs, it's corticosteroid, prednisone. A potential adverse effect can be drug-induced hyperglycemia. Osteoporosis, corticosteroid, prednisone, increase in fracture risk. Constipation, anticholinergic, antihistamine, narcotics, all slow gastrointestinal tract motility. Parkinson, antipsychotic, aggravate movement disorder. Hypertension, non-steroid anti-inflammatory drugs as aggravating drugs, and potential adverse effect. Fluid retention increases blood pressure. Benign prostatic hypertrophy, anticholinergic, antihistamine drugs, it can be urinary problem. Selected interaction of drug, food, and nutrition. Selected interaction drug of food and nutrition. Drug therapy can contribute to anorexia. It can be digoxin, narcotics, non-steroid, non-inflammatory drugs, others. Dry mouth and contribute to poor intake. It can be grouped and drugs as clonidine, beta blockers, tricyclic antidepressants, antihistamines. Frequent laxative use, fat-soluble vitamin deficiency. Food can impair absorption. Some medications such biphosphonates. Selected drug-drug interaction as exams, absorptions impaired by resins and fiber products. Metabolism. Cimetidine inhibits oxidative metabolism of several other medications. Induction of enzymes by alcohol or phenytoin increases metabolism of other agents cleared by the same enzymes. Renal excretion. Competition for renal tubular secretion. Digoxin renal excretion reduced by several other antiarrhythmics. Non-steroid inflammation drugs reduce renal prostaglandins and decrease renal blood flow, and thus may reduce effect of some diuretics. Protein binding changes are important for highly protein-bound agents with narrow therapeutic index, particularly when drug is displaces and metabolism is inhibited. Example, warfarin with sulfonamides, which both displace drug, increased free concentration, and inhibit hepatic metabolism. And we now will talk about principles of prescribing drugs elderly. It's very important. And you should ask patient for yourself, for your experience, is the drug therapy required? Treatment, no treatment. If required, what should be the aim? If required, with appropriate one. The ones with good therapeutic margin or less abuse liability. Is the drug taken tolerable? Smallest number of drugs that should always be used. Medication errors and non-compliance should also be accounted for. Contributors for non-adherence with medication regimen in elderly patients. Complex or frequently changing schedule, larger number of medication, more than 8, adverse reaction, difficult to open containers, expensive medication, rectal vaginal modes of administration, confused about brand name, trade name, and duplicates. And Birch criteria was for initial developed but expert consensus panel in 1991 as the most widely cited criteria used to assess an appropriate drug prescriber. The criteria list of medication considered potentially inappropriate for use in older patients, mostly due to higher risk for adverse events. Medications are grouped into 5 categories: those potentially inappropriate in most older adults, those that should typically be avoided in older adults with certain conditions, drugs to use with caution due to the potential for harmful adverse effects, drug-drug interaction, and drug dose adjustment based on kidney function. And a type limitation of the criteria is that they are most applicable to clinical care in the United States, as they focus on medication available in that market. These criteria were updated in 2023. Avoid use of rivaroxaban for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism due to higher risk of bleeding in older adults than other direct-acting oral anticoagulants. Avoid warfarin as initial therapy for venous thromboembolism or non-valvular atrial fibrillation unless alternatives, direct oral anticoagulants, are contraindicated or there are substantial barriers to their use. Avoid sulfonylureas as first or second-line monotherapy or add-on therapy due to higher risk of cardiovascular events, all-cause mortality and hypoglycemia than alternative choice. If a sulfonylurea must be used, then short-acting agent is preferred. Avoid the initiation of oral transdermal estrogen in older women. Topical vaginal estrogen remains appropriate as treatment for symptomatic vaginal atrophy or urinary tract infection prophylaxis. The prescribing should be considered for all the women already using non-vaginal estrogen replacement. Avoid initial of aspirin for primary prevention of cardiovascular disease. Consider the prescribed aspirin as all the patient already taking it for primary intervention. And you see, if assume and all the patient what drug-related problem. It's include polypharmacy first place, adverse drug reaction, subtherapeutic drug dosage, overdose, failure to receive a prescribed drug, adverse effect or drug withdrawal, drug use without an indication, duplication of drug therapy, drug-drug interaction, and underuse of beneficial therapy. Polypharmacy is often used as a term for undesirable drug prescribing practice in elderly, but is only one aspect of problem. Drug safety in the elderly. Do we have a problem? Yes, we have a problem. Top 10 medicine reported by EU member states in 2010, women and men 80 more. It's acetylsalicylic acid, warfarin, levofloxacin, furosemide, acenacoumarol, enalapril, rovacoxib, digoxin, clopidogrel, and ciprofloxacin. Why do we have a problem with safety of drug treatment in the elderly? Many drugs prescribed to older patients not tested in the age group. Prescribers lack education about how to treat older patients with drugs. Older people are treated for their symptoms, not based on diagnosis. Effects of drug treatment in the individual patient is not monitored. Lack of coordination between different doctors' treatment of an individual treatment. Patient lacking knowledge about drugs and how to use them. What we can to improve drug safety in the elderly? European Medicine Agency Geriatric Medicine Strategy. Ensuring that medicine used by geriatric patients are of higher quality and appropriately researched and evaluated throughout the life cycle of the product for use in the population. Improving the availability of information of the use of medicine for older people, thereby helping inform a prescription. Establishing specific pharmacovigilance activities. Assessing care of vulnerable elder projects. Another expert panel has identified quality indicators for appropriate medication use as a part of assessing care of vulnerable effects (COV) projects. These indicators begin with practical suggestions on how to improve prescribing practices, document the indication for a new drug therapy, educate patients on the benefits and risks associated with the use of the new therapy, maintain a current medication list, document response to therapy, and periodically review the ongoing need for drug therapy. Drugs that can cause problems in older adults. It can be non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, gastrointestinal bleeding, renal dysfunction, diuretic, hydrochlorothiazide, furosemide, bleeding, many drug interaction, plus fall down and hydrochlorothiazide. You remember it can be when it's long prescribing and long administrated. It can be non-myeloma cancer with if and factor of risk of it's long photosensibilization on patients this group. Angiotensin converting enzyme inhibitor, lisinopril, hypertension, renal dysfunction, antidepressants, amitriptyline, confusion, hypertension, constipation, orthostatic hypertension, interval QT prolongation, opiate, morphine, confusion, disorientation, constipation, prednisone, osteoporosis, gastrointestinal problems, hyperglycemia, benzodiazepam, flurazepam, osteoporosis, gastrointestinal problems, hyperglycemia. Common drug interaction in elderly patients. For example, if we're talking about angiotensin converting inhibitor, enzyme inhibitor plus potassium, it can be hyperkalemia as a risk. Angiotensin converting enzyme inhibitor plus kalisparic diuretic, hyperkalemia, hypertension, digoxin plus antiarrhythmic, bradycardia, arrhythmia, digoxin plus diuretic, antiarrhythmic plus diuretic, electrolyte imbalance, arrhythmia, diuretic plus diuretic, electrolyte imbalance, dehydration, benzodiazepam plus antidepressant, benzodiazepam plus antipsychotic, sedation, confusion, false. And you see CCB group, nitrate, vasodilatator, diuretic, deep hypotension. Non-steroid, non-inflammation drugs plus thiazolidindones plus CH, fluid retention, CHF, exacerbation, BPH group plus anticholinergic urinary retention, CCB group plus constipation, narcotic plus constipation, anticholinergic constipation, exacerbation of constipation, metformin plus CHF group, hypoxia, increased risk of lactic acidosis, non-steroid non-inflammatory drugs plus gastropathy, increased ulcer and bleeding risk, non-steroid non-inflammatory drugs plus HTN, fluid retention, decreased effectiveness of diuretics. And as example, plus another example is common drug-drug interaction in elderly patients. It can be angiotensin converting enzyme inhibitor plus non-steroid and inflammatory drugs. It can be hyperkalemia, decline in renal function. Ciprofloxacin plus olanzapine. Ciprofloxacin inhibits cytochrome 1A2. As a result, the plasma concentration of olanzapine increases and toxicity of olanzapine increases. Digoxin, furosemide, hypokalemia may increase risk for digitalis intoxication. Nitroglycerin, sildenafil, increased risk of severe hypertension. Spironolactone, potassium chloride, hyperkalemia. Verapamil, atenolol, bradycardia and hypertension. Warfarin, acetyl salicylic acid, increased risk of bleeding. Anticholinergic drugs, dementia, potential outcome, delirium. Antipsychotic, Parkinson's disease, worsening of Parkinson's disease symptoms. Aspirin, peptic ulcer disease, gastrointestinal bleeding. First generation calcium channel blocker, congestive heart failure, worsening of heart failure is potential outcome. Non-steroidal anti-inflammatory drugs, decreased renal function, renal failure. Non-steroidal anti-inflammation drugs, heart failure, worsening of heart failure. Thiazides, gout problems, worsening of gout. Tricyclic antidepressant and epilepsy, lower sizes, therefore also is toxic levels of tricyclic antidepressant. And won't pay attention warfarin drug interaction. Double check before starting a new medication with warfarin. It's important cytochrome P450 interaction. Drug highly bound to albumin, which can be displaced by other proteins bound medication, aspirin and others. Risk of adverse outcome from drug interaction is significant both from bleeding, abrexose, thrombotic events. Most common important interaction: other anticoagulants, antiplatelet agents, steroid, antibiotics can often reduce the dose of warfarin empirically and follow the INR closely, and you should dosing help. What can we do to improve drug safety in the elderly? A responsible physician. Have comprehensive view, so see the whole patient as part of whole. Complex approach. See the whole patient as a part of whole. Self-care and non-pharmacology treatment always come in first. The drug list is a medical records for drugs and should always be updated and correct. Teamwork, user competencies. The vast majority of adverse events can be divided in tasks. In this group, dose-dependent, more frequent and higher doses, which can occur in individual when exposed to sufficient dose of the drug. Type are augmented, representing 80% of all the patients. Immune mediated of non-immunological hypertensive reaction, non-dependent of the dose, it can occur in predisposed individuals. These reactions are therefore unpredictable and more serious, usually detected only after the drug enters the market. Type B bizarre represented 20% of all adverse reaction in older person. Drugs associated with type 1 reaction are generally of low therapeutic index, are commonly used in older patients as a therefore adverse reaction in the group. A type reaction is a predictable pharmacologic effect. Knowing homeostatic dysregulation, age-related changes in pharmacokinetics and pharmacodynamics and drug interaction make adverse reaction definitely or possibly preventable in this population. However, adverse reaction can be difficult to diagnose in older patients as they often have no specific symptom, whether false fatigue, cognitive decline, or constipation, all of which have different etiologies. Despite the difficulty, it is estimated of average prevalence around 11% of adverse reaction. It means that what kind of adverse reaction more often you can see in all the patient. It's gastrointestinal complication, gastrointestinal bleeding, peptic ulcer, erosive gastritis, nausea, vomiting, cardiovascular disorder, hypertension, bradycardia, arrhythmia, falls, metabolic endocrine complication, hyperglycemia, renal and urinary disorders, renal impairment, acute renal failure, electrolyte disorder, hypokalemia, hyperkalemia, hyponatremia, and nervous system disorder, depressed level of consciousness, mental status changes. Studies have shown that beta blockers, antibiotics, oral anticoagulant, dioxin, angiotensin converting inhibitors, antiaplastic, calcium entry blockers, opioid, oral antidiabetics are most frequently non-steroid inflammatory drugs as the main drug class that causes of adverse hospitalization in older adults. Main drug classes, you see that we paid attention, and general principles of medication management for all the patient. Review all medication, ask patient for bring all medication in. You won't prescribe it for non-specific symptom or without clear diagnosis. Update and discontinue medication where able. Remember, medication lists accumulate if untended. Consider drugs adverse effects if you observe decline in physical or cognitive function of self-care abilities, and medication boxes set out in advance may be helpful. Its strategy master, minimize number of meds, alternatives to be considered, start low and to slow, titrate therapy, educate patient, and review and monitor regularly. Strategy master, minimize number of meds, alternative to be considered, start low and go slower, titrate therapy, educate patient, and review and monitor regularly. Prescribing principle: when a new medication is needed, start low, go slow. Treat adequately to achieve goals of therapy. Provide patient education using written instruction to reinforce proper drug use at home. Avoid complex dosage schedules if possible. Dear colleagues, thank you very much for your attention. I hope these lectures will be very useful on your daily practice. I will be thankful if you will find ability and subscribe on my channels. It will increase audience and it will be sharing knowledge which will be very useful for healthcare professionals, because if you see that it's a general problems and not just, for example, for some category of healthcare professionals, some specialty. It's a global problem, and I will share my knowledge with you with big interesting for you, and I will be very thankful if you leave your questions and you see my email in the first page of slide, and I will be very thankful if you will send me your question. It will help me to prepare charge-free lectures for you. It will be avoid of lethal cases and will increase safety of patients as well. Thank you very much, my dear colleagues. See you later on my future lectures.